Assalamu alaikum. I'm Dr. Liha and I'm going to discuss the urodynamic study, and Dr. Osama will be the moderator. The objectives for today's discussion will be the urodynamic study, its indication, different components of urodynamic studies, its setup, cystometry, and pressure flow studies. Introduction. Urodynamic study is the dynamic study of transport, storage, and voiding function or dysfunction of lower urinary tract. It uses a set of measurements of relevant physiological parameters of lower urinary tract to assess its function and dysfunction. The aim of urodynamic study is to answer the clinical questions and reproduce the patient's symptoms and determine the cause of it by UDS observations. It involves the assessment of function and dysfunction of lower urinary tract and include the actual tests that are performed UDS studies or UDS observation during the testing. What is most important is that the clinician has a clear-cut clinical question to answer by performing this study. It is most useful when history, physical examination, and simple tests are not sufficient to make an accurate diagnosis or to institute the treatment. It has a clinical applicability in two general scenarios. Number one is to obtain the information needed to make an accurate diagnosis for what is causing symptoms, for example, lower urinary tract symptoms, or if a patient has urinary incontinence. Number two is to determine the impact of disease that has the potential to cause serious and irreversible damage to upper and lower tract, like neurological diseases such as spinal cord injury, MS, and radiation cystitis.
One thing is very important, that urodynamics is a very specialized study. It's an invasive study, and it's a cumbersome study for the patient. So it is not a baseline study, it's a specialized test. So whenever you order a urodynamic study for a patient, you must know what you want to know after the study. You must have you must have test history and examination of the patient. You must have questions in your mind regarding the patient's symptomatology, and then you order a urodynamic study. And after the urodynamic study, by observing the findings or the urodynamic observation, you can get the answers of your questions, and then you can instigate the treatment. Or in some cases, if you see a response to the treatment, then you can see how your treatment has fared. So it is very important. You must have some questions in your mind before ordering a urodynamic study, rather than just order the UDS and then see what is happening.
Indications: to identify or rule out the factors contributing to lower urinary tract dysfunction and assess their relative importance. To allow a prediction of possible consequences of lower urinary tract dysfunction for upper urinary tract. To understand the reasons for failure of previous treatment via whether there is recurrent incontinence, mixed urge or stress incontinence, patients with neurological disease and mismatch between sign and symptoms, or if there is any outflow obstruction or neurogenic bladder. For male patients specifically, UDS is indicated in men who have had previous unsuccessful invasive treatment for lower urinary tract symptoms prior to further invasive treatment.
So this point is very important, that, for example, if you have performed a TURP of a patient, and after TURP patient is unable to void or his voiding is not successful. So if you are planning another invasive treatment for that patient, you must need to have the urodynamic study prior to that, because in urodynamic study, you can see that if the bladder is underactive, or if the bladder is atonic, or if it is a small capacity bladder. So in this scenario, the urodynamic study can help you vastly before going to another invasive treatment.
Okay. In men considering invasive treatment who cannot void more than 150 ml, those with bothersome voiding lower urinary tract symptoms and having Qmax of more than 10 ml per second. And when considering invasive treatment in men with bothersome voiding lower urinary tract symptoms and post-void residual of more than 300 ml, or age of more than 80 years or less than 50 years.
So in point number 2, you can see the patient who can't void greater than 150 ml. How can you assess that before UDS? Anyone can answer that? Before urodynamic study, if patient is not voiding more than 150 ml, how can you assess that? Frequency volume chart. So before urodynamic study, you take the history, and along with the examination, you need to order an FVC or a bladder diary, and you also do ultrasound pre-post voids or UFM. So if in the frequency volume chart his voided volumes are persistently small, less than 150 ml, then he might have a small capacity bladder. So you have to assess that, you can order in urodynamic study. Similarly, if the post-void residual of a patient is greater than 300 or greater than 500, because normal capacity is 400 to 500. If his post-void residual are 800 or 600, that means the person or the patient must have an underactive bladder. It is a large capacity atonic or underactive bladder. So before going to the invasive treatment, you must raise suspicion that this patient has a large capacity underactive or maybe atonic bladder. So these patients need to have a urodynamic study before going to any invasive treatment.
Urodynamics is particularly of benefit in objectively identifying the functional abnormalities of lower urinary tract, such as those with urinary incontinence and bladder outlet obstruction. However, particularly in video cystometry, it may also assist in identifying the structural abnormalities such as prolapse associated with stress urinary incontinence, vesicovaginal fistula, urethral diverticula, or upper tract VUR. In context of male patient, it can be useful in demonstrating the attenuation of prostatic urethra in association with prostatic outlet obstruction or confirming the diagnosis of bladder neck obstruction.
So this slide is related to the video urodynamic study. So can anyone tell what is UDS and what is the video UDS? Or just simply, what is the video UDS? Munazza?
We just take different x-rays from different angles while maturating or while we fill the bladder by injecting our dye, and then we check the flow, and we check for strictures also and other abnormalities.
That is fluoroscopy.
That is
Fluoroscopy, by taking images, we take image by fluoroscopy. That is a video UDS. So in video performing video UDS, you can get additional information like vesico-urethral reflux if the patient is having VUR, or if there is a prolapse associated with stress incontinence, or the condition of the bladder neck during voiding phase, if the bladder neck is opening or not, if it is closed. So these information you can get only if you are performing the video urodynamic study rather than just a simple urodynamic study.
So here is the picture for upper and lower urinary tract. We already know the kidney and ureter forms the upper urinary tract, while bladder and urethra makes the lower tract. A short discussion for micturition reflex. It is a complete autonomic spinal reflex to get urine outside the body that is facilitated or inhibited by higher brain centers in adults. Micturition involves two main steps. Number one is a tension in wall of bladder, which rise above the threshold level, and nervous reflex at 150 to 200 ml of urine volume.
So making it simpler, so what is voiding or what is the function of lower urinary tract? That is to store urine at low pressure and then evacuate urine when the times come, when the condition is socially acceptable. So right from the start of the baseline, you understand it by the bladder. It has a compliant structure. Its function is to store urine and at low pressure. And then when socially acceptable times come, when the person would want to go to the void, when he or she go to the washroom, he or she can evacuate urine, while in between she must remain continent. So the basic simple understanding is that, and then you understand it further.
These are the phases of micturition. As Dr. Sama said, it has to, the function of bladder is to store and evacuate the bladder. So in a storage phase, there are bladder filling phase in which detrusor muscles should relax and urethra and pelvic floor muscles should contract. While patient having first sensation, detrusor is still in relaxed position, but urethral contraction increases, while pelvic floor is still in contraction.
So that leakage could not occur. Incontinence could not occur.
On emptying, when patient has a normal desire to void, detrusor muscle contract and urethra and pelvic floor muscles relax, and that results in micturition. And then again, storage and bladder filling phase start.
So that is the normal physiology, what normally happens.
Functional abnormalities of lower urinary tracts. These can be divided into the following: storage dysfunction, emptying dysfunction, or combined. It can further be classified according to anatomical region of lower urinary tract. If someone has a bladder dysfunction, it could be overactive or underactive. If it is overactive, it causes the failure to store urine, and if it is underactive, it causes the failure to empty the bladder. While if patient having bladder outlet dysfunction, again it is overactive and underactive, but in this case it is vice versa. If bladder outlet dysfunction is overactive, the patient is unable to empty the bladder, while if it is underactive, the patient is unable to hold the urine.
So eventually, when abnormalities occurs in all these things, so what happens? The patient had symptom. Patient has your lower urinary tract symptom, or in some cases there is a risk of upper tract damage. There is a risk of renal failure, or if there is a bladder become decompensated, or if there is a ureter become refluxing, then there is a risk of upper tract damage. So you have to understand it in context of the lower tract and the upper tract.
UDS observations. There are conventional UDS and ambulatory UDS. Conventional UDS is the one which is a standardized functional assessment of lower urinary tract. It involves both invasive and non-invasive measurement of bladder and urethral function to objectively assess the lower tract function and dysfunction. While ambulatory UDS is a functional test of lower urinary tract using natural filling and reproducing the subject's everyday activities. Now, what will be the UDS setup? It should be ideally it is a room of suitable size, should be dedicated to urodynamics, with door lock and curtains around the entry and exit to the room. Room should be large enough to allow the patient to lie down, to have a catheter placed, and also to stand and sit on a commode as necessary. There should be no distractions from people walking in and out of the area for other reasons. There should be a urotechnician and nurse available. UDS table, and UDS chair.
So if you have visited the UDS room, the patient is in a very awkward position, in a lithotomy position or during a UDS room, so there should be a privacy for the patient. And it is an invasive study. So also, if you are performing a UDS in a neurogenic patient, if he is on a wheelchair or on a stretcher, you must have an additional pupil to help performing the UDS along with the UDS technicians.
So this is our setup of UDS in SIUT, which is basically it is a video UDS setup. The CM and monitor shows the video UDS system, while this is the UDS table, and this is a working station that monitor system. And this thing basically is the area where we place the transducers and filling. These are the pictures when patient performing this. Now, how to prepare the patient? The patient should be counseled regarding why and how the test is being done. The patient should arrive to the urodynamics testing with 3 to 7 days bladder log or bladder diary, pad wet test if applicable, and complete validated urinary questionnaire such as UDI-6 or AUA symptom score. Ask patient to come to the test with a reasonably full bladder and try not to urinate immediately before testing starts. Ask if patient has a diarrhea or constipation, and hold UDS if a female patient has a menstruation.
So at this point as well, I'll just go back to the previous slide. So again, the point is very important that patients should come with voiding diary, FVC, and again, a symptomatology should be reconfirmed before starting the UDS as well. And another very important thing here is that about the medication. What about the medication? The patient, if you are performing UDS to know what is the treatment response, then if the patient is already on any anticholinergic medication or beta-3 agonist, you should not stop before, because you want to see the treatment response. But if you are performing the UDS for the first time and you have already started the patient on a medication, so you must stop those medication beforehand, 3 to 4 weeks beforehand, so that the finding could not mask because of these drugs. So that is very important as well. Another thing important is that the blood pressure check. Before starting the study, you must check the blood pressure. And sometime you must perform the study while doing BP monitoring. So why is that? Anyone can give an idea? Nadia, maybe? Yes, sometimes you are performing the UDS on a neurogenic patient. So, a very important thing is autonomic dysreflexia. So, if bladder filling can cause provocation and can cause blood pressure fluctuations, so it is very important to know the blood pressure beforehand, and if it is rate, it should be controlled. And sometimes you need to perform it during the BP monitoring. Another important thing is the diabetic patient. You must check the RBS sugars. If the sugar is raised, again, you should be aware, or you should control the blood sugar, because it is a stressful test. So the patient can go in decay or any uncontrolled sugar. So in women as well, you must need to confirm if the LMP if you are performing the video urodynamic study, and see if the patient has menstruation, because a catheter must be placed in the rectum or the vagina. So this thing important as well.
Urine culture should be performed prior to invasive UDS. Those with symptomatic UTI, UTS should be delayed until the treatment completes. No need of antibiotic prophylaxis in patient without UTI risk factors, while antibiotic prophylaxis required in patient with neurogenic lower urinary tract dysfunction. These are the ICS guidelines, which we'll be discussing in further slides.
These are basically the urodynamic observation or the definitions. So what is meant by phasic overactivity? What is urodynamic stress incontinence? So we will be further discussing in the further slide, and this is the standardized ICS. So the terminology must be very accurate. Whenever you explain UDS finding in your examination, your terminology should be very accurate, and according to the ICS standardized classification, that is the urodynamic observation. So again.
So urodynamic components. The term urodynamics encompasses an investigation of urinary tract, the simple to sophisticated, including FVC volume chart, bladder diary, PET testing, UFM with and without residual PVR, pressure flow studies, which include cystometry, video cystometry, and ambulatory urodynamics, urethral pressure studies, and others include IV urodynamogram or ultrasound cystodynamogram.
So UDS is not just UDS we have in our 4th floor suite. Just performing a simple uroflowmetry, that is also a UDS. Measuring the pre-post void residual, that is also the UDS. So UDS encompasses a variety of the investigation, not just what we have in our files or in the lithotripsy setup. It is one of the components. Okay.
So we can divide the urodynamic components into non-invasive and invasive. As Dr. Sama said, UFM, which is usually performed in our clinics, is a non-invasive UDS. and post-void residual also. While when we considering UDS, though it becomes synonymous with the pressure flow study, then most clinicians refer to either cystometry or video cystometry while using the term UDS.
So at our center, just go back. So invasive UDS has multiple components. It has a cystometry, pressure flow study, electromyography, urethral pressure profilometry, and the video UDS. At our center, we are at this time performing cystometry. We don't have electromyography or urethral pressure profilometry, but these are also component of UDS, and you must know these as well while going for the examination.
We do have electromyography. It is available in that unit that we have, but the problem is we don't have a neurophysiologist with us, and since we don't have it, so the interpretation of EMG graph is a little bit out of sync. So because these things work well when the whole team is actually working on a different level. So if your understanding is coming up to the level of maybe placement of artificial sphincter, then you would like to do EMG pre-operatively and post-operatively. It doesn't apply only for artificial, it applies for autologous sphincter also. So Manju Saab is there, he will bear me out that if you want to implant autologous graft, for instance, piriformis muscle and pyramidalis muscle for the purpose of sling operations, then you must know the pre-op electromyography as well as the post-op electromyography as well as the leak point pressures. So I think that the whole team has gone up to the level of understanding urodynamics to a greater extent now, and they can embark upon this aspect, which is the only thing left in the whole armamentarium.
Yes, sir.
So मेरे ख्याल में आप लोग जा सकते हैं उसमें.
With few modifications in that machine, we can do that as well.
Yes.
But we are not doing it, and sometimes the experts, we arranged few workshops and they came here and they were saying that the advantage of this finding, they said there is not too much, but we can do on this machine as well, urethral pressure profile.
Right, sir.
But this is a specialized test. So I think we should all be there, maybe me, you, Dr. Abbas, Dr. Mohsen, who are reviewing the urodynamics in outpatient clinics.
Yes, sir.
So our presence should be there.
Yes, sir.
And we should read these graphs. Technologists should not read these graphs. We should read and we should report these graphs. As I
Yes.
saw in other countries where I went for training. So technologist was doing these tests, but the
Yes.
report was generated by
Yes, sir.
a
So
specialized doctor. So we should
Yes,
report these.
absolutely, you are
Yes.
right, sir. And we have
Mm.
discussed at the starting that the person who are ordering the UDS, he or she must have clear-cut questions in his or her mind. So what thing he want to see, what question he have, and then after the seeing the urodynamic observation, his or her question must be answered, and he can initiate the treatment or change the treatment accordingly.
That
So
is
exactly.
important.
Yes.
What do you want to see? What is your question?
Absolutely.
And that should be correlated with the urodynamics.
Yes.
Patient's complaints and doctor's question and patient's findings.
Yes.
So that will be rightly seen by a doctor. And
Exactly.
he should be there.
Yes, sir.
So that will be then great
Yes,
for
sir.
patient and for this technology,
Yes.
which is very beneficial for these patients.
Right, sir.
So once you have taken care of patients who are with spinal trauma, who are with neuropathic bladder syndromes, then the actualization or realization of neurophysiology and the neurourology clinic would come up. And when that maturity is reached, then you would be needing electromyography and urethral pressure profile and things like that. So I think now is the time, because once you go up to that level, then in order to know where your spine is actually overacting in a way that the whole bladder and urethral unit is overwhelmed by something else, then you must do something called posterior isotomy. But before doing all these things, you must know where to gauge your procedure. The gauge of the procedure is these things.
Right, sir.
Now moving forward towards the cystometry, it is a dynamic measurement of detrusor pressure during filling phase. It is not only the method by which pressure-volume relationship of bladder is measured, but it also an interactive process which permits the examination of motor and sensory function. It is used to assess the detrusor activity, sensation, capacity, compliance, and control of micturition process. Cystometric studies help to measure the bladder capacity and function. Bladder problems including overactive bladder, reduced bladder capacity, and incomplete or inability to empty the bladder completely can also occur with pregnancy. So we can order this test into those patients. A CMG should be performed in a patient with relevant neurological condition like spinal cord injury, MMC, and other at risk of upper tract impairment, with or without symptoms.
The last point is very important. While during cystometry, the patient should be attentive. He should be well versed. He should be understanding your question, and he should be telling you what is happening with him. So whenever you're ordering a urodynamic test, you must assess if the patient is able to understand your commands, or if he is able to tell the finding while performing the UDS. For example, if it is a CP child, or if a child is of Down syndrome, so it would be futile investigation. So you must need to the mental awareness of the patient is very important at this, well, in this phase or while any UDS.
But a person who is doing it, he should be expert, because in children, our pediatric team is doing urodynamics.
Yes, sir.
And it is not easy to perform urodynamics in small children.
Yes, sir.
So they are doing it, and they have generated the system and process.
Yes, sir.
For doing it. So I think if doctor will be there, then or expert will be there who is reading it and who is applying it on patients. So then that will be possible as well. Then those patients where there are these difficulties.
Yes, sir.
Sure, Dr. Zoma, may sorry, coming back to the purpose of this discussion is to make our resident population understandable that this is something which is very valuable, this is something which is available, and this is something which is on the horizon of urology as an investigative tool for the last 30 years or so. So now, for an exam point of view, if somebody is sitting at my back, is thinking that maybe it's just one station in talks and maybe one question in or one or two MCQs in the theory paper, it's not like that. Now, all over Pakistan, cystometry and profilometry is, even if the system is not available, the understanding is there. In all the units, whether it's in Peshawar, Lahore, or Rawalpindi, the students, they always go towards video lectures, and they prepare themselves in order to understand the very fine basic concepts of urodynamics. So you can't just shy away from 3 chapters or 4 chapters in Spitz urology written on this subject and then can say that I am a urologist. You see, you can be a urologist just being involved in urolithiasis or maybe general urology minus uro-oncology minus neuro-urology. But how many things can you minus in this day and age? You can't minus everything from urology. This is urology of this day as well as urology of future. So if anyone is sitting with the concept that this might not be available, this might not be there in future for them to understand or interpret, I think they will be on a wrong track of understanding.
So for transducers, these are the hardwares that allow pressure in the patient to be measured and measurements transferred to the UDS system and thus converts the mechanical energy into electrical energy. These transducers, the transducer for the fluid fill systems are external and adjusted to the height of superior border of symphysis pubis, which is the approximate anatomical level for base of bladder. There are types of transducers, the external charge fluid pressure transducers. ICS recommends the use of these catheters due to their easier use regard to the zero pressure and reference height. This is the picture for the external charge fluid pressure catheter, and we are using this type of catheter in our setup. Second is a catheter mounted transducers. These are mounted on the end of special catheter. They do not require fluid fill system, and external proximal end of the catheter is connected directly to the electronic record system. Here are the pictures for catheter mounted transducers. Air charge pressure sensing transducer. They are the newest, consisting of reusable cables with the tiny balloon fixed on the distal end of catheter. This is a picture of air charge fluid catheter. These are the disposable catheter, and this is the reusable cable.
So-
While these two pictures of the catheter mounted transducers.
We have fluid filled transducers at our setup, and fluid filled in studies or in there is air filled transducer as well, but we have fluid filled transducer. And while during the fluid filled transducer, you must empty the air bubbles before performing the study, and it must be placed at the level of the superior border of the pubic symphysis. Can anyone tell me why is that? Why is superior border of pubic symphysis? Because it is very close to, one thing is it is very close to the bladder, and we are measuring the pressure at the level of the bladder, and during all our studies, the transducer or the machine must be at the level of the superior border of the pubic symphysis, and that pressure should be 0 to the atmospheric pressure. So that is our reference point. And whenever patient changes position, we must readjust our transducer and our whole setup.
Bladder catheter. This is a specialized catheter, usually of 6 to 7 FR and made of polyvinyl chloride and polyurethane. It has multiple lumen for concurrent pressure monitoring and fluid infusion simultaneously. The catheter is introduced to the bladder with an aseptic technique using local anesthetic lubricant. Here is a picture of this bladder catheter with 3 lumens. One is for infusion, one is for measuring the pressure, and one is for airlock. Second is a rectal catheter, which is introduced into the rectum or vagina to measure the abdominal pressure. Single lumen perforated balloon rectal catheter with inserter. This showing the rectal catheter, where one is the airtight closure and one is for the pressure measurement.
What if the patient does not have a rectal surgery performed? Then how can we assess the abdominal pressure? Can anyone tell he or she had an APR or something like that? Nadia?
Then we place it in stoma.
Yes, Shumaila said it. So if we can place it in the ileostomy or a colostomy to measure the abdominal pressure.
Now, how to perform CMG? Bladder access by transrectal catheter, rarely by percutaneous suprapubic tube, will be accessed. Filling medium, either gas or liquid, that is water, saline or contrast medium at body temperature, will be filled. Ideally, filling should be performed in a standing position. Bladder filling either by diuresis or filling through a catheter. Filling rate should be, there are 3 types of filling rates: slow, medium, and fast. The physiological rate is slow, which is up to 10 ml per minute, while medium rate is 10 to 100 ml per minute, which we usually used. Fast is more than 100 ml per minute.
Before starting the filling, empty the bladder. There should be no urine before filling phase starts. So if the patient can void, you must perform a UFM or check the post-void residual. If the patient is cannot void, he or she has a catheter, you must empty the catheter. So before starting the filling, the bladder must be empty. And rate, just physiologically, as we all know, the urine output is not like 100 ml per minute, or so the slow filling rate should be 10 ml per minute physiologic. Medium is 10 to 100. So here we perform in adults 20 ml per minute. So sir can bear me out, sir. Because of number of the patient and the number of burden we have, we perform at a fast rate. So does it really produces those symptoms, or does it answers our questions, or it must be at the physiological rate?
It depends upon the process. If there are not, you do not see abnormal findings during filling,
Yes, sir.
and at the rate of 10 ml and increase it, and there are no rise of significant pressures, then you can increase the speed of the fluid.
Right.
Otherwise, keep it slow. And here comes the importance of bladder diary.
Yes.
In bladder diary, you see the true capacity of the bladder. When patient bring it, the record of 3 days, and you can see there in bladder diary that how much is the capacity, bladder capacity of that patient. If it's 200 cc or 150 cc, then there is no need to increase the speed, keep it slow. If it's 500 cc, 100 cc, then you can safely increase the flow, but again, keep an eye on the pressures, because sudden rise of pressures can cause a problem can generate the severe urgency, and you then will have to stop the procedure or decrease the speed.
Right.
So fluid should be increased slowly, and you should also refer the bladder diary, and so that is the prerequisite for that.
Right, sir.
Now, there is another logic behind low
Right.
flow, and the
Yes.
logic is if the transducer is directed towards the trigone and you increase the flow, then trigonal stimulation will actually rise the pressure and will cause the first sensation coming up earlier than later. So
Right,
if you
sir.
want to have that anomaly taken out of the context, don't start with something like greater than 100 ml. The safest point is to start with between 10 to 25 and then move on, as Murli has said.
Right, sir.
In children and patients with known bladder hyperactivity, it will require slow filling rate. The reference point, as already discussed, upper border of symphysis pubis. All systems should be 0 to atmospheric pressure, and there should be no air bubbles in the tubing. These all we already discussed. Okay, the one thing is during cystometry, the pressure traces should be marked with annotation of patient's subjective sensation. These include first sensation of bladder filling at the volume. We noted the volume at which first sensation occurred, the volume and pressure at first desire to void, and when patient has strong desire. Regular cuff test at interval of 1 minute or every 50 ml of infusate assure that the maintenance of quality of the pressure transmission throughout the test. So we should also have these cuff tests during the UDS. This is
A practical point is since I have been doing it before your team comes up and before I think you were actually born. So at that time, I was all alone. And whenever the cuff test was done, it was done for the purpose of seeing one, the transducer is actually in place. It hasn't gone out because we don't have, at that time, I don't know now, but we don't have at that time the retaining mechanism of a balloon. So all the transducers, all the catheters were actually not self-retaining. They were actually tied down by simple adhesives. So it is very important that you must know that it is still there in the bladder. So the cuff test is something that can give you that all the things are properly placed. Similarly, when you ask the patient to cuff, then you must put down the marker on the screen, because if you don't put down the marker on the screen and if somebody else is doing, then you must, or you might interpret it wrongly, because there is nothing which is written over there as cuff test. So whenever you yourself as a doctor, you are doing it and asking or giving a command to the patient that you must cuff, then you put a marker over that, and that marker is there on the screen as well as on the graph. So in that way, the whole process becomes meaningful and the diagnosis is actually done simultaneously. So nobody would actually do it afterwards if he is doing it himself or herself. So that is one of the advantages of doing it by yourself.
So this is a picture in which there are the transducers and catheter placed over the bladder and in the rectum. This one is the pump, which is connected with the irrigation fluid, which are infusing. And these transducers are connected to the system. And graph is shown in the three traces: the P abdomen, P vesicle, and P dead. It's abdominal pressure, vesical pressure, and diffuser pressure.
These traces are very important. During cystometry, you will be observing the traces. So in this picture, we have three: the abdominal pressure and the diffuser pressure. The diffuser pressure cannot be measured directly. It is measured by the formula by subtracting P abdominal from the P vesicle. So on the x-axis, whenever there is a graph, there is an x-axis and there is a y-axis. On the x-axis, there is the volumes, there are pressures. So as the volumes is filling, you see the pressure. So you see the graph, you see the pressure, you see the line. If the diffuser pressure is going up or not, or if it is just close to the zero. So as the filling rate increase at the volume infiltrate, you are observing the traces of that cystometry. So at every 50 ml, you perform a cough. To the function of the cuff is two. One is to, if there is any stress incontinence, you can see the leakage. Along with these three traces, in our UDS study, there is another just below. We have two traces as well, where we can see the flow or any leakage. So if there is any leakage, you can see on cough test, and then you can diagnose the patient has a stress incontinence. And also by cuffing, you can see if your transducer are correct or not by observing. There must be a rise in the abdominal and the vesical pressure, but transducer pressure should not rise on cough. That means your systems are working. So while doing cystometry, you are observing this graph as the volumes are increasing and seeing the pressures.
CMG parameters, as we discussed, there are three traces on the graph. Intravesical pressure, this is the pressure within the bladder. Abdominal pressure, which is the bladder pressure surrounding the bladder estimated from rectum, vagina, or extraperitoneal pressure or bowel stoma. Detusal pressure, which is the not a direct measure, it's a component of intravesical pressure created by forces on the bladder wall that are both passive and active. It is estimated by subtracting the abdominal pressure from the intravesical pressure, as Dr. Sam already said. Normal CMG capacity, for normal patient, the capacity should be 350 to 500 ml or 600 ml. First desire to void should occur between 150 to 200 ml. There should be constant low pressure that doesn't reach more than 6 to 10 centimeter of water above baseline at the end of filling. Provocative measures like coughing, fast fill, etc. should not provoke a bladder contraction normally. Absence of systolic detrusor contraction, no leakage should occur on coughing. Avoiding detrusor pressure, rise of less than 70 centimeter of water with a peak flow rate of more than 15 ml per second for a volume of more than 150 ml. There should be residual urine volume of less than 50 ml. This is the graph showing normal CMG. Here we can see the vesical pressure, abdominal pressure, detrusor pressure, and as Dr. Osama said, volume and flow. Whenever we start the study, we check the baseline vesical, abdominal, and pdat with detrusor pressure, and we check the cough. We will perform the cough test so that we have a baseline that patient have no leakage, should no leakage occur on cough. And when we start study, we start from the infusion. As this graph shows, detrusor, abdominal pressure and vesical pressure spikes. These are correlating with each other. That means whenever patient had cough, abdominal pressure increases, and in that case, vesical pressure also increases. This is the pdat detrusor graph, which is showing no rising spike. So that means the bladder is okay. Again, this is a
Just going quickly because we have shortage of time.
Just a point here, because one graph is actually missing, and that one is the volume graph. You see, the volume graph should have been risen from 0 to whatever 519 and then goes on. So ये थोड़ा सा नहीं है. जैसे जैसे आपके दूसरे आप चीजें देख रहे हैं ना, वैसे वैसे वो भी होना चाहिए था, तो वो कहीं पे शो नहीं हो रहा. ठीक है, लेकिन कॉन्सेप्ट सही है, आपको चीजें सही है.
So this is the complete filling phase. This whole is the filling phase.
ये नीचे वाला ग्राफ है, लास्ट वन वाला, इसमें कुछ फाइंडिंग्स तो हैं अब ना?
नहीं, यहाँ पे फिलिंग फेज स्टॉप हो गया 519 पे, फिर ये voiding phase स्टार्ट हो गया. Permission to void 519 पे there is a permission to void, and then there is a voiding phase, there is a dead to. थोड़ा सा yes sir, unstable है, थोड़ा सा fluctuations है detrusor pressure में, लेकिन it more or less close to the zero. It is more or less close to the zero.
इसको जरूर मेंशन करना.
Yes sir.
नहीं, क्लोज टू जीरो नहीं हो सकता. वजह उसकी है कि
these small spikes, this one, these
अराउंड 300 ml जो है ना, आपको फर्स्ट सेंसेशन तो आनी चाहिए थी ना. देयर इज नो फर्स्ट सेंसेशन हियर. आपने कहीं पे जिक्र ही नहीं किया इसका. वो आगे का पहले होना चाहिए था ना.
इसको भी मार्क करना चाहिए.
मतलब 500 के बाद अगर फर्स्ट हो रही है तो इसका मतलब है ये कुछ सुपर वॉइडर है या उसका ब्लैडर बहुत बड़ा है.
There must be first.
So it's not normal.
First sensation, then strong desire to void.
172 पे होगी ना, तो वहां पे एक मार्कर लगना चाहिए था.
Yes sir.
क्योंकि पेशेंट बताएगा कि मुझे महसूस हो रहा है, लेकिन दैट महसूस हो रहा है इज एक्चुअली कोरिलेटेड विद समथिंग इन द पीवेज. वहां पे होना चाहिए था. अब 172 का फ्लैट लाइन है, एक लाइन आ तो रही है. हाँ,
ऊपर से जो ब्लैक है ना, इससे भी छुपा हुआ है.
हो सकता है, ये भी हो सकता है.
ये प्लीज हटा दें इसमें से.
Okay, ग्राफ पे चलते हैं, ये हम चीजें डिस्कस कर चुके हैं, टाइम थोड़ा शॉर्ट. अब abnormal.
So there is a video, shall I play it?
We have some graph of
About to undergo a urodynamic study to investigate the function of your bladder. These tests will help evaluate the organs that store and pass urine, such as the bladder, urethra, and tissue that connects them. Some of the tests include uroflowmetry and cystometry. Uroflowmetry is used to measure the rate of urine flow during urination. Cystometry is used to check whether the bladder is emptying and filling properly. This animation shows how a typical urodynamic study is performed. Your doctor might begin with uroflowmetry. You will be asked to urinate on a special toilet in private. This toilet will measure the flow of your urine. Afterwards, an ultrasound of your bladder is made to see how well it emptied. If you have to undergo cystometry as well, a catheter will be inserted into your urethra after receiving a local anesthetic. Then one more catheter is placed in your rectum. Both catheters measure the pressure in your bladder and your abdomen. Sensors on your abdomen monitor the activity of the pelvic muscles. Your doctor will fill your bladder with sterilized fluid using the catheter. You will be asked to cough or bear down to test your bladder reaction. Your doctor will check if there is any urine leakage and if you feel the need to urinate. When your bladder is full, you will be asked to urinate while the pressure is being measured. The catheters and sensors will be removed at the end of the cystometry test. After the tests are done, your doctor will discuss the results with you and any further treatment you may need.
Professor Manzoor sir, would you like to share your experiences or any important things?
Thank you. I think it was a very good presentation and excellent discussion, and it was all about the basics of the urodynamics. But I want to add one thing, that it's an essential part of any academic urologic center anywhere in the world, and everybody must learn who is interested in managing the neurogenic disorders or blood outlet obstruction or incontinence, like Dr. Murli is doing functional urology. But for trainees, it's also important because this urodynamics provides the scientific basis of the management of many urologic disorders, especially the functional urology, like neurogenic bladder, incontinence of urine, and blood outlet obstruction. So for me, it was very also a revision for me, and she presented very well, and you have a good discussion. I enjoyed this whole session. Thank you.
Thank you very much.
Thank you, sir. Thank you.
And I invite all of the resident. They want to see urodynamic. You can go to Force Fluid Suite, and then you can come to us. We will teach you. You will teach you how are the traces. So anytime you are most welcome. It is a very important part of exam.
Thank you so
Dr.
much.
Asad. Thank you, Dr.
Thank
Murli.
you. Thank you.